Hello, my name is Dorothea Orem, and I wrote the Self-Care Deficit Nursing Theory. I was born in Baltimore, Maryland in 1914. In the early 1930s, I received my nursing diploma from Providence Hospital School of Nursing in Washington, D.C. I completed my Bachelor of Science in Nursing in 1939 and my Master's of Science in Nursing in 1945. Both degrees were obtained from the Catholic University of America in Washington, D.C. I also received several honorary doctorate degrees, including an honorary doctorate of science from both Georgetown in 1976 and Incarnate Word College in 1980. I was given an honorary degree, Doctor of Humane Letters from Illinois Wesleyan University in 1988, and finally a doctorate honoris causa from the University of Missouri in 1998. I should also mention a few of my awards I have received throughout my career. These include the Catholic University of America Alumni Achievement Award for Nursing Theory in 1980, the Linda Richards Award from the National League for Nursing in 1991, and I was named Honorary Fellow of the American Academy of Nursing in 1992. I developed my theory based on the question, what is the condition that indicates that a person needs nursing care? I noticed that the inability of a person to maintain adequate self-care was correlated with health and wellness. This made me really think about what was necessary and what needs a patient has to maintain health, and what are the appropriate nursing interventions. My theory is a grand theory. It's called the self-care deficit nursing theory, also known as Orem's model of nursing. A grand theory is described as something which means the theory covers a broad scope with general concepts that can be applied to all instances of nursing. The central philosophy of my theory is that all patients want to care for themselves and are able to recover more quickly by performing their own self-care. My theory is primarily used in primary care or rehab where patients are encouraged to be independent, but it can be applied to a variety of situations. There's three components to my self-care theory. The first is theory of self-care. The self-care a patient performs independently to maintain health and well-being. Second is the theory of self-care deficit. Specifies when nursing care is needed. When a patient is unable to and or limited at providing efficient self-care, the nurse steps in. Third is the theory of nursing systems. Describes how the self-care deficit will be met by the nurse, may it be partially, wholly, supportive, or via education. The theory of self-care can be broken down into three more categories. The first is universal self-care. Requisites are needs all people have, like air, water, food, activity, rest, and hazard prevention. Developmental self-care requisites are maturational and situational. Maturational, to progress to a higher level of maturation. Situational, prevent against harmful effects of development. And health deviation requisites, needs that come up based on a patient's condition. The nursing theory. Environment. The environment is linked to the individual, forming an integrated system. The environment is implied to be external to the individual. Person. The individual is linked with the environment, which together they are formed into a whole. The individual functions biologically, symbolically, and socially. Health. Health has a physical, psychological, interpersonal, and social aspects. It is a state in which human beings are structurally and functionally whole or sound, whereas illness occurs when the individual cannot perform self-care because of the structural or functional limitations. Nursing. It involves assisting the individual with self-care so that they are able to recover from their illness, disease, or injury more quickly. Nursing research study that I chose was called The Effect of Supportive Educational Intervention Developed Based on Orem's Self-Care Theory on the Self-Care Ability of Patients with Myocardial Infarction, a randomized controlled trial. This trial was done in Iran using patients with cardiovascular disease. that suffer from lack of knowledge about the disease, consequently are not able to fill their own self-needs. The design was a randomized controlled trial. The method used was that they recruited a random sample of 66 patients with myocardial infarction who had been recently discharged from a coronary care unit. The study setting was 2 university hospitals located in Iran. Patients were randomly allocated to either the experimental or the control groups. Patients in the experimental group received education, support, and counseling, while the patients in control group received no intervention. They employed a demographic questionnaire and the myocardial infarction self-care ability questionnaire for data collection. The findings were, after the study, patients in the experimental group had higher levels of self-care knowledge, motivation, and skills compared to the pre-study readings and the control group. The conclusion: the supportive educational intervention developed based on Orum's self-care theory can improve non-hospitalized patients' self-care ability and positively affect public health outcomes. Consequently, using the developed program for providing follow-up care to non-hospitalized patients is recommended. Patient case study. Recently at work, an 85-year-old male was admitted. He lives alone, all of his kids have moved away, and he's recently widowed. He was admitted to the ER, and his diagnosis was AMS, rhabdo, CHF exacerbation, DKA, and multiple open wounds. He had been found on the floor, incontinent, and altered mental status by his neighbor. He had been down for several days before anyone noticed. In the emergency room, he was confused and lethargic and a poor historian. From his previous admissions, they noted his past medical history to be CHF, diabetes type 2, dementia, PVD, and CAD, with a past surgical history of CABG, an aortic valve replacement, and a pacemaker. In the unit, after a few days of treatment, the patient was more alert and told the doctors that his wife had recently passed, that he couldn't remember what meds to take, he needs assistance walking, and he needs help around the house. His wife had been his primary caretaker for years. Once we found this out, we immediately alerted the social worker, who came in to eval him, and also ordered a PT-OT eval. With this, PT and OT set him up with a walker for his unsteady gait for at home. They also set him up with a visiting nurse to complete wound care and help him with his medication administration. So in conclusion, we use the self-care deficit nursing theory every day in our nursing practice. It's more important than people would think, but that's what we're there for.